Hi everybody, this is Kim. My presentation is on diabetes mellitus type 2. For my case study, my patient's a 68-year-old man. He presents to his family practitioner's office with a chief complaint of blurred vision. Lately it seems to be getting worse. He said the blurred vision has been present for the last month and also complains of fatigue and lack of energy. This has prohibited him from working in his garden. Patient's history: he's got a history of hypertension for 18 years, dyslipidemia for 8 years, gouty arthritis for 16 years with a uric acid urolithiasis outbreak, but no attacks in the last 3 years, hypothyroidism for 15 years, and has been overweight for 25 years. His family history includes a living mother that is currently diabetic. His father died of unknown causes at an early age, and he has one sibling that died of breast cancer at age 48. Social history: he is a retired candy salesman. He's been married for 46 years and has 3 children. He denies tobacco use and drinks 1 to 2 glasses of homemade wine with his meals. He does report that he's compliant with his current medications. Current medications are lisinopril 20 milligrams PO once a day, allopurinol 300 milligrams PO once a day, and levothyroxine 88 micrograms PO once daily. He has no known drug allergies. On examination, he does report occasional polydipsia, polyphagia, fatigue, weakness, and blurred vision. He denies any other symptoms. He is overweight. He is 5'6" and 77 kilograms, which gives him a BMI of 27.3, and this is considered overweight. His vital signs are within normal limits. For labs, his random glucose is 202, fasting glucose was 157, and his hemoglobin A1C is 7.8%. His fasting lipids: total cholesterol is 280, HDL is 27, LDL 193, and triglycerides 302, and all of those are outside of normal parameters. Also, we did perform a monofilament test, and that was normal. So for this patient, the diagnosis is diabetes mellitus type 2, and that was determined by an elevated hemoglobin A1C, abnormal random glucose, and abnormal fasting glucose. Also, this patient does need treatment for hyperlipidemia due to his abnormal lipid profile, and no current treatment is in place. Pathophysiology: diabetes is a metabolic disease. It's characterized by hyperglycemia. It results from insulin resistance or insulin deficiency, sometimes both. The prevalence of diabetes mellitus has increased throughout the world, especially in the older population. The diagnosis of diabetes mellitus is based on hemoglobin A1C levels greater than or equal to 6.5%, fasting plasma glucose levels greater than or equal to 126, or random glucose levels greater than or equal to 200 in people that have symptoms. Type 2 diabetes is the most common form of diabetes. It affects over 18% of adults between the ages of 64 and 74. Most common risk factors are age, obesity, high blood pressure, low activity, and family history. As a side note, metabolic syndrome is a group of disorders. It would be obesity, dyslipidemia, prehypertension, and elevated fasting blood glucose, and that points to a higher risk of diabetes and cardiovascular complications. This patient does present with all of these risk factors. In addition to the genetic predisposition of type 2 diabetes, many organs contribute to insulin resistance. Insulin resistance is defined as an inadequate response of insulin-sensitive tissues, for example, liver, muscle, and fatty tissue, to insulin. Obesity is present in most patients that have type 2 diabetes due to an alteration in adipokines. Those are the hormones produced in adipose tissue. which can have an effect on the pancreatic function. Elevated levels of serum-free fatty acids and cellular deposits of triglycerides and cholesterol are also part of that. Serum-free fatty acids bind to receptors and cause changes which interfere with cellular insulin signaling, and they promote inflammation. Obesity also causes release of inflammatory cytokines from the adipocytes, which induce insulin resistance. Diabetes can be masked for many years. Eventually, islet cell or beta cell disruption and dysfunction will occur and lead to insulin deficiency. Chronic hyperglycemia can cause issues with the eyes, like retinopathy, cataracts, neuropathy, particularly in the feet, hypertension and stroke, or cardiovascular disease, kidney disease. It also puts patients at an increased risk for infection and slower healing. The treatment and goal for this patient. Diabetes requires a comprehensive and collaborative treatment. This helps to ensure the ideal outcome for the patient. It's important to focus on medication management, but also nutrition and exercise and proper follow-up to prevent complications. The American Diabetes Association recommends an A1C goal of less than 7%, for adults, and they also recommend treatment guidelines that don't just focus on the pharmacological treatment, but diet, exercise, and comorbidity management. Management of diabetes and the associated risk factors does increase the number of medications for most people, especially in the elderly population. However, most first-line treatments recommend monotherapy to begin with, and the addition of complementary medications if needed. We're also going to want to reduce this patient's weight to 150 pounds, which will place him at a BMI of 24.2, which is within the normal healthy range. Like I stated, we do want a hemoglobin A1C less than 7, and we'd like to get his lipids to better levels as well. This particular patient did inquire about using alternative therapy. He said he had a neighbor that uses cinnamon, fish oils, and alpha-lipoic acid with just diet modification, and that's successful for her, and that's something that I will talk to him about. We will probably incorporate some of these options as they would be considered safe for him. The plan, we're going to add metformin 500 milligrams PO twice daily. This is the recommended first-line treatment for new onset diabetes. Alpha-lipoic acid, we'll add 600 milligrams PO once daily. We're going to need to add simvastatin. This patient has not currently been on treatment for dyslipidemia, so we're going to do 20 milligrams PO once daily at bedtime. We'll continue his current medications. He's on lisinopril, allopurinol, and levothyroxine. We want to consult an ophthalmologist for a comprehensive eye exam. He was complaining of blurred vision, which can be a sign and symptom of diabetes, but it would be best to go ahead and get that looked into further. Definitely, it is recommended to consult a registered dietitian for nutritional management. It's shown that patients that are provided intensive nutritional intervention counseling and diabetes support have a better success rate with the weight loss and the glycemic control. I would recommend this patient always sees a podiatrist for any further foot treatments, even just basic nail clippings, as patients that are diabetic do have issues with their feet and can get non-healing wounds on their foot. So podiatry is a better option for them. I would recommend a follow-up in 1 month. I am going to have this patient do just about 30-day self-monitoring of his blood glucose at home. It isn't really necessary from the research that I've done that patients go to this route immediately, but for new onset diabetes, they do recommend some self-monitoring. And then if that's if those levels are looking pretty good with your treatment, you can discontinue that. And then a follow-up in 3 months for labs. We'd like to do follow-up lipids, obviously, and then kidney function as well, just to make sure there aren't any complications from the medications. And then a follow-up lipid panel to see if we've had any success with the simvastatin. For pharmacology, metformin is the first-line treatment recommendation for type 2 diabetes. It has been shown to decrease microvascular complications, help with weight management, and reduce cardiovascular events. It's an oral biguanide anti-hyperglycemic drug, and it's generally effective. It increases the peripheral glucose uptake and utilization, decreases hepatic glucose production, and the intestinal absorption of glucose. This helps to improve glucose tolerance and lower the plasma glucose levels. Metformin is not known to produce hypoglycemia, since it does not stimulate insulin release, and it does not generally cause weight gain. In some instances, is actually shown to promote weight loss. Also, metformin is very cost-effective. We're going to add simvastatin. It's an anti-lipidemic that blocks synthesis of cholesterol in the liver. It induces an increase in LDL receptors, which induces the liver's extraction of LDL precursors. This decreases LDL by up to 63%, decreases triglycerides by up to 43%, and increases the HDL levels up to 17%. This response may not be as aggressive in diabetic patients, which is one of the reasons we would want to follow up with a lipid panel just to make sure we're providing the best treatment. Because the patient is interested in natural and herbal therapies, I wouldn't want that to be the only treatment for him, and that's a discussion that we would have, but I would be willing to consider alpha-lipoic acid. There's no real hard evidence that cinnamon is effective for patients, and maybe at a later date we can discuss adding in the fish oils. For now, alpha-lipoic acid is shown to protect against the oxidative damage to cells caused by diabetes. It's shown to positively influence the regulation of glucose and reduce blood lipids, so it could work for two different things here. Most patients with type 2 diabetes have lipoprotein disorders, and studies have shown that alpha-lipoic acid can assist with weight control, triglyceride control, and glucose management. I did do a check to make sure that there weren't any major interactions with the alpha-lipoic acid and the other medications, and there were none. And there were no major interactions with any of the newly added medications. Teaching is going to be ideal for this patient. We're going to start with teaching at this visit, but then, as I stated, we are going to do a consult to a registered dietitian. Really need to get some really good education on his diet and activity. So we're going to go over diabetes, what it is, in a language that's good for this patient. We'll discuss a diabetic diet, decreasing added sugars and alcohol intake, and then kind of sticking to fruits, vegetables, and proteins for his meals for the most part, just to give him a basic understanding, and then the registered dietitian would get a little bit more in depth with that. We're going to discuss increasing activity. As his blood sugars start to level out, I think he'll find that his fatigue and lack of energy will start to subside, and maybe he can get back into his gardening. We'd like to see a decrease in weight. I think a weight of 150 is doable for this patient. He is currently 164 pounds, so that's only 14-pound weight loss, and we won't expect that overnight, of course. We are going to go over blood glucose monitoring. I just want to ask this patient to check his blood sugars morning and night just for 30 days, bring in the log, and then we'll decide from there if that needs to be continued. We'll discuss signs and symptoms of hypoglycemia, although with metformin this generally isn't an issue. It's good for the patient to know. And then obviously we're going to talk about no grapefruit or grapefruit juice with simvastatin, as that's a contraindicated combination. If you have any questions, please let me know. Thank you.